Okay, let's unpack this. Imagine your body just spent, 9 months building an entirely new human being.
Right.
You go through delivery, you enter the postpartum phase, and maybe you experience this rapid weight loss.
Yeah, which is very common.
Very common. And you're dealing with the sheer exhaustion of it all. And suddenly you realize that a part of your body you probably never gave a second thought to, your labia, has completely changed.
Completely.
It is deflated, it is causing you physical pain when you walk or exercise, and biologically, that area is basically mimicking menopause.
Yes.
And that is the biological perfect storm millions of women face, yet we almost never talk about the clinical reality of fixing it.
It is an incredibly complex diagnostic landscape. I mean, for a long time, cosmetic gynecology was treated almost like a menu.
A menu.
Yeah, like a patient just points to what they want and the surgeon delivers it. But when you are dealing with fluctuating postpartum hormones, changing metabolic states, and rapidly shifting anatomy, treating it like a simple aesthetic fix is a recipe for clinical failure.
Which is exactly the mission of our deep dive today. We are exploring how clinicians actually evaluate candidate suitability for what is colloquially known as a labial puff.
Right, or in the medical literature, labia majora augmentation.
Exactly. Specifically for women who have gone through rapid postpartum weight loss. We are pulling from a lot of sources today. We've got international plastic surgery guidelines, the 2026 clinical updates from the International Society of Aesthetic Plastic Surgery, recent MDPI clinical trials on dermal fillers, and insights from leading global aesthetic gynecologists.
And if you look closely at these sources, you start to realize this isn't just a niche aesthetic concern. Evaluating these patients is a masterclass in how modern medicine blends aesthetic goals with profound physiological function.
I love that.
But to understand how a doctor evaluates a candidate, we first have to understand the biological mechanics of why this specific patient is sitting in the clinic in the first place.
Right, the deflation.
Yeah.
So how does a woman go from normal anatomy to a state where the outer labia completely lose their volume? Like, what is actually happening there?
Well, the literature refers to this as the genitourinary syndrome of lactation.
Genitourinary syndrome of lactation.
Yes. So when a woman is breastfeeding, her body is flooded with a hormone called prolactin. This is a state of hyperprolactinemia, which essentially signals the body to prioritize making milk above all else.
Okay.
But biologically, high levels of prolactin suppress estrogen production.
Oh.
So the body enters a hypoestrogenic state,
So her estrogen levels just plummet while she's nursing.
down to levels you typically wouldn't see until a woman hits her late 50s or 60s.
Why not? Just from nursing.
Just from nursing. And estrogen is the primary hormone responsible for maintaining tissue thickness, elasticity, and robust blood flow in the vulvovaginal area.
So without it, everything just kind of slows down.
Exactly. The tissue thins out, the collagen breaks down. Now, if you combine that severe hormonal depletion with rapid postpartum weight loss, the labia majora, which are the outer padded lips, they're largely composed of fat pads.
Right.
They can rapidly deflate. They lose their underlying architectural structure, leading to a flattened, wrinkled appearance.
It's so interesting because reading through Dr. Katerina Zimanova's interviews on this, she uses this fascinating concept. She treats the perineum and the vulvar area as a woman's second face.
It's a very apt way to look at the evolution of the specialty.
Yeah, she points out that, 20 years ago, facial plastic surgery was purely about tension, just pulling loose skin as tight as possible.
The old wind tunnel look.
Right, exactly. But now, facial aesthetics are all about restoring lost volume. You don't just pull the fabric tighter over a deflated couch cushion, you put the stuffing back in so it functions as a cushion.
And that word function is what dictates the clinical evaluation. The labia majora are not just there for visual aesthetics. They are shock absorbers.
Oh, right.
They act as a protective cushion. They reduce friction from clothing. They protect the inner structures during exercise, daily activities, and intimacy.
Yeah.
When that cushion deflates, women experience severe physical discomfort.
Wait, let me pause you there because I have a structural question about this.
Sure.
If the outer lips, the majora, if they shrink and lose all their volume, doesn't that naturally expose the inner lips, the labia minora?
Yes, it does.
So do they suddenly look abnormally large? Like, how does a doctor actually know what part of the anatomy they're supposed to be fixing?
What's fascinating here is you've just hit on one of the most dangerous diagnostic traps in cosmetic gynecology. It's known clinically as pseudoprotrusion.
Pseudoprotrusion, meaning it's an optical illusion.
Oh,
yes.
really? For decades, the standard reflexive procedure was a labiaplasty. surgically cutting away and reducing the labia minora. The
Okay.
patient would come in complaining that her inner labia were sticking out and causing friction. But astute clinicians started realizing that in many of these postpartum or rapid weight loss patients, the minora hadn't grown a single millimeter.
Wow.
They were simply being unveiled because the outer envelope, the majora, had completely collapsed.
Oh, wow. So the inner lips were always that exact size. They were just previously tucked away and protected by a fuller outer lip.
Right, so if a clinician fails to evaluate the entire architectural balance and just defaults to a surgical reduction on the minora, they are cutting away healthy functional tissue.
That's terrible.
It is. They are worsening the aesthetic balance and completely ignoring the real issue, which is majora volume loss.
Mm.
A proper evaluation requires the doctor to step back and ask, is this actually an excess of inner tissue or is it a deficit of outer volume?
That distinction completely changes the surgical game plan.
Completely.
So let's say the clinician successfully navigates that trap. They recognize it's a volume deficit. The logical next step in my mind would be a fat transfer,
Right.
taking fat from the patient's abdomen or thighs and just putting it back into the labia where it is needed.
Autologous fat transfer is absolutely considered the gold standard for durable, long-term volume restoration. You are using the patient's own tissue.
Makes sense.
But, and this is a big but, if a patient is actively losing weight postpartum, a responsible clinician will immediately halt the evaluation process for this specific procedure.
Why is that? I mean, if she wants her volume back and she clearly has the fat to spare from her abdomen, what is the medical reason for waiting?
Well, it all comes down to the metabolic environment. When a surgeon performs a fat transfer, they aren't just injecting a sterile, non-living filler. They are transplanting living, breathing cells.
Okay.
For those fat cells to survive the transfer, they have to undergo a process called angiogenesis.
Angiogenesis.
Yes. They need to quickly establish a new blood supply in their new location to get oxygen and nutrients.
Okay, so they need to plug into the local grid to survive.
Exactly. But if you transfer those living fat cells into a body that is in the middle of active rapid weight loss, you are sending them into a metabolically hostile environment.
Oh, because the body is trying to lose fat.
Right. The patient is in a systemic caloric deficit. Her entire chemistry is sending a continuous endocrine signal that says, break down fat for energy.
Ah. Doing a fat transfer during rapid weight loss would be like trying to plant a new garden in the middle of a severe drought.
That's a great way to put it.
The environment is actively hostile to growth. The seeds are just going to wither and die.
The transferred fat will simply be reabsorbed and metabolized by the body at an incredibly high rate.
So it just disappears.
It does. The procedure will fail. And not because the surgical technique was flawed, but because the metabolic timing was wrong.
Wow.
The body's internal messaging overrides the surgical intervention.
So how does a doctor evaluate if the timing is right? Is there a specific window they're looking for?
According to the clinical guidelines we reviewed, there is a very rigid metabolic checklist. First, the patient's weight must be absolutely stable for a minimum of 3 to 6 months.
3 to 6 months of no changes.
Right. Second, she needs to be within 5 to 10 pounds of her ultimate goal weight. And third, she must be at least 6 months post-delivery and post-weaning.
Post-weaning, meaning she has to have completely stopped breastfeeding for at least half a year.
Because that is how long it takes for the prolactin levels to drop and the estrogen levels to normalize. You cannot accurately plan a surgical volume restoration until the hormonal landscape has stopped shifting.
Because things are still changing.
Exactly. If you operate while she's still hypoestrogenic, you are operating on temporarily thin tissue.
But this brings up a massive practical dilemma. I mean, if a woman is, say, 4 months postpartum, she's actively losing the baby weight, she's still breastfeeding, but she is experiencing severe friction, pain during exercise, and a massive loss of confidence right now. Does she just have to suffer? Does she just wait it out in pain for another year until her hormones settle?
No, she doesn't have to wait. This is where the clinician's evaluation path splits.
Okay.
If the patient fails the metabolic checklist for a fat transfer, they might be evaluated as a candidate for hyaluronic acid, or HA fillers.
Wait, HA fillers like the ones people get in their cheeks or lips?
The exact same underlying mechanism, yes.
Really?
And the clinical data supporting this is becoming incredibly robust. We looked at a 2026 MDPI randomized controlled study, the ESALANE study.
Yeah, I have that one right here.
They evaluated the use of cross-linked HA fillers, specifically for labia majora hypertrophy.
Let me stop you for a second. Cross-link and hypertrophy. What do those actually mean in this context?
Hypertrophy is just the medical term for severe volume loss or tissue shrinkage.
Okay, hypertrophy is shrinkage.
And cross-linking refers to how the filler is manufactured. Natural hyaluronic acid is a liquid that the body metabolizes in a few days.
Oh, I didn't know that.
Yeah, it breaks down very fast. But in a lab, they can bind the molecules together. They cross-link them, creating a microscopic scaffolding.
So it makes it thicker.
Exactly. This turns it into a durable gel that can hold its shape and provide structural cushioning for months.
That makes a lot of sense. But is it safe to inject that into a woman who is still lactating?
According to dermatological and gynecological consensus, yes. Assuming the patient has no active infections like mastitis. HA fillers are generally considered lactation safe. It is a highly localized injection.
Right.
The gel stays exactly where the doctor places it, it doesn't cross into the bloodstream, and it has no mechanism to affect the milk ducts.
So it's basically an in-office procedure.
Often done under local anesthesia, taking maybe 30 minutes, with practically zero downtime.
Okay, looking at this from the outside, if HA fillers are lactation safe, they have no downtime, they don't require going to an operating room, and avoid the trauma of liposuction.
Sure.
Why would a clinician ever evaluate a patient and recommend a fat transfer instead? Especially when fat grafting requires surgery and costs upwards of $4,000 or more.
Well, it comes down to longevity, sheer volume requirements, and ultimately economics.
Economics?
Yeah, HA fillers are highly effective, but they are temporary.
Right, they break down.
Exactly. The body naturally breaks down that cross-linked gel over 6 to 12 months. So it's purely a maintenance treatment. You are renting the volume.
You're renting it, right. I like that phrasing.
Fat transfer is considered a permanent structural change. Usually, about 50 to 70% of the transferred fat survives that initial healing phase.
Oh, so not all of it makes it.
No, but the part that does establish a blood supply, it stays there indefinitely.
Got it.
Furthermore, if a woman has experienced severe deflation from rapid massive weight loss, the sheer amount of volume needed to restore the labia majora might require multiple syringes of HA filler.
Oh, I see. Because fillers are priced by the syringe?
Yes.
So it adds up.
Very quickly. At that point, the economics flip. It becomes drastically more expensive to continually purchase that many syringes of temporary filler every single year compared to paying for a one-time surgical fat transfer.
That's a fascinating trade-off. And you mentioned the Esalane study earlier. Does the data show that injecting filler actually solves the physical pain, or does it just look better?
The clinical outcomes are actually striking. The study measured improvements using two specific tools, the Female Sexual Function Index, or FSFI, and the Global Aesthetic Improvement Scale, or GAIS.
How do they actually measure those things? Is it just a questionnaire where they ask, hey, are you happy?
It's far more clinical than that.
Okay.
The FSFI specifically measures physical parameters. Are you experiencing friction while walking or biking? Is there physical pain during intimacy due to a lack of cushioning or lubrication?
So real, tangible things.
Yes. The patients treated with HA fillers showed statistically significant improvements in those functional metrics.
Wow.
And the GAIS measures patient satisfaction with the visual restoration. The spikes in both scales prove that restoring this volume fundamentally changes a patient's physical comfort and psychological well-being.
Okay, so a clinician has evaluated the diagnosis, avoiding the pseudoprotrusion trap. They've assessed the metabolic clock, deciding between waiting for a fat transfer or using HA filler in the interim.
Right.
But I keep thinking about the physical reality of rapid weight loss. Okay.
If someone loses 50 pounds quickly, the skin isn't just deflated, it's stretched out.
Yes, it is.
Pumping filler into severely stretched out skin sounds like trying to fill a plastic grocery bag with water. It's just gonna sag, right? If we connect this to the bigger picture, that is an excellent point, and it brings us to the final and perhaps most crucial clinical checklist, evaluating skin quality.
Skin quality.
Once the timing and the method are decided, the clinician has to evaluate the physical canvas. They use tools like the Motakef classification system.
The MOTAC classification system, what does that measure?
It's a diagnostic scale that measures the exact millimeter proportions of the vulva, specifically how far the labia minora protrude past the majora.
Oh, so it gets very precise.
Very. It gives the surgeon an objective mathematical roadmap for exactly how much volume is needed to restore balance.
Okay.
But numbers on a chart aren't enough. The clinician has to physically evaluate the elasticity of the skin envelope itself, usually through something as simple as a snap test.
A snap test? Literally pinching the skin to see if it snaps back?
Precisely. If the rapid weight loss has been so extreme that the elastin fibers in the skin are permanently broken, the skin will just hang there, redundant and severely loose.
Okay.
If the skin has lost its ability to recoil, Pumping it full of heavy fat or dense HA gel will just weigh it down further. It will look unnatural and feel worse.
So what happens to that patient? Do they just get turned away?
No, but the clinician's evaluation pivots entirely away from pure volumization.
Right.
That patient requires a surgical excision.
Oh, they have to cut the skin.
Yes. The surgeon has to physically cut away and remove the excess stretched skin to tighten the envelope, often combining that with a modest amount of volume restoration.
Right.
You have to fix the container before you can worry about what's inside it.
That really highlights why the initial physical consultation is so critical. But there's a whole other side to this final checklist in the literature that frankly surprised me with how much emphasis it gets, and that's the psychological screening.
Many leading aesthetic gynecologists argue it is the most important part of the evaluation.
Because you're dealing with patients who are already in a highly vulnerable state postpartum.
Absolutely.
So how does a doctor differentiate between a woman who is just normally insecure about her changing body and a patient they shouldn't operate on?
Well, a responsible clinician is actively screening for body dysmorphic disorder, or BDD.
Right.
If a patient as distress is rooted in a psychological fixation where they perceive a catastrophic deformity that doesn't actually exist clinically.
Right. They see something no one else sees.
Exactly. No amount of perfect surgical technique is ever going to relieve their distress. The doctor has a strict ethical obligation to refuse surgery and refer that patient for psychological support.
It's a crucial safeguard. And even for patients who pass the screening, it sounds like the consultation is heavily focused on managing expectations.
Absolutely. For instance, if a patient is cleared for a fat transfer, they must be psychologically prepared to accept the realities of organic healing.
Because it's not perfectly predictable.
Right. Fat can resorb unevenly. The human body is incredibly rarely perfectly symmetrical in how it establishes a blood supply.
So one side might retain 70% of the fat, and the other side only retains 50%.
Which happens.
Meaning they might need a second, minor touch-up session a year later to perfect the symmetry.
Exactly. If a patient sits in the consultation chair expecting a one-and-done, flawless, machine-like result, they're clinically evaluated as a poor candidate.
That makes sense.
The patient has to be a rational partner in this process, understanding the biology behind what they're asking the doctor to do.
So what does this all mean? When you lay it all out like that, it completely shatters the illusion that aesthetic gynecology is just superficial cosmetic work.
It's far from it.
These clinicians aren't just looking at a localized physical issue. They're calculating a woman's metabolic timeline, mapping her endocrine system, charting her architectural anatomy, testing skin elasticity, and performing a psychological evaluation.
It has to be that holistic. Because, as the sources point out, you are intervening in a woman's overall quality of life. You are restoring fundamental comfort and confidence during a period of massive physical vulnerability.
It really is an amazing intersection of science, timing, and empathy. And as we wrap up, I was reading through the section on autologous fat transfers again, and I came across this biological reality that completely blew my mind.
Oh, yeah.
Yeah, I think it just perfectly encapsulates how dynamic all of this is.
Are you talking about the metabolic memory of transplanted fat cells?
Yes. Okay, so we established earlier that a successful fat transfer means those transplanted fat cells undergo angiogenesis, they develop a blood supply, and they survive permanently in the labia majora.
Right. They become living integrated tissue.
They are living adipocytes.
Yes.
But because they were harvested from the patient's own body, say from her lower abdomen, they retain the metabolic memory of abdominal fat.
Which is incredible.
So imagine a woman gets a labial puff via fat transfer. The results are great, her weight is completely stable, but a few years later, she gets pregnant again.
And naturally, she gains 40 or 50 pounds during the course of that new pregnancy.
Exactly. Because those transplanted fat cells in her labia are still living, metabolically active abdominal fat cells, they will respond to that systemic weight gain exactly as they would have if they were still on her stomach.
It's wild to think about.
The fat cells in her labia will actually expand and grow significantly as she gains weight during the pregnancy.
It is a phenomenal reminder that aesthetic surgery isn't about molding inanimate clay. You are rearranging living biology.
It is wild. A reminder that even after the most precise, highly evaluated cosmetic intervention, the body isn't a static sculpture.
No, it's not.
It remains a breathing, ever-changing ecosystem, and those transplanted cells are just along for the ride.
It forces both the clinician and the patient to view these procedures not as a final destination, but as a single chapter in the ongoing life of the patient's body.
Something to definitely ponder the next time you think about the permanence of cosmetic medicine.